Assalamu alaikum everyone. आज हम कर रहे हैं Gastroesophageal Reflux Disease, short form GERD. ये वीडियो थोड़ी सी लंबी होगी, so I'm sorry for that, but let's get right into it. This disease develops when the esophageal mucosa is exposed to gastroduodenal contents for prolonged periods of time. Okay? And this, the exposure to this acid leads to the symptoms and of course at the end esophagitis. ये जो picture है, it perfectly summarizes कि क्या-क्या causes हैं इस problem की, ठीक है? We're gonna start from the top. Dietary factors, जो लोग बहुत ज़्यादा chocolates, fatty foods, alcohol, चाय, coffee वगैरह consume करते हैं या बहुत obese होते हैं, overweight होते हैं, they have a higher tendency to develop this disease और उनके लिए यही advice होती है कि weight अपना lose करें या फिर अपनी जो है खाने पीने की ज़रा आदत को सही करें, ठीक है? तो the reason that obesity and a weight gain increases this problem is because आपके जो abdomen का जो pressure है वो थोड़ा ज़्यादा हो जाता है, तो वो ज़रा it pushes against this area. This also happens in pregnancy. Heartburn is very common in pregnancy. आपने सुना होगा. तो it has the same reason as obesity. Abdomen में ज़रा pressure ज़्यादा रहता है. ठीक है, then we have the next cause is defective esophageal clearance. ये अक्सर इसलिए होता है because patient को for any reason esophagitis होता है, ठीक है? तो उसकी वजह से the peristaltic activity is not as good in the esophagus. लिहाजा जो है नीचे से acid ऊपर आ रहा होता है. ठीक है, अब ये जो lower esophageal sphincter tone है, ये बहुत ज़रूरी factor है. ये tone maintain करता है esophagus और stomach के separation को, ठीक है? और ये सिर्फ तभी खुलता है जब हम मतलब जब esophagus से खाना नीचे stomach तक आना हो. उसके अलावा normal condition में this stays closed. But what happens is जिनके अंदर इन sphincter की tone कम होती है या फिर for any reason there is inappropriate relaxation, तो इनमें heartburn ज़्यादा हो जाता है. Then another very common cause is hiatus hernia. There are two types of hiatus hernia जो हम आगे देखेंगे. तो hiatus hernia you can understand कि अब ये जो diaphragm के level पे होना था यहाँ sphincter type चीज़, तो वहाँ पे एक tight closed place होनी थी. लेकिन hernia की वजह से अब there is no tight closed constricted place. You know, this area is open here. This is free to move. जो भी fluid होगा यहाँ free to move होगा, तो that's why it causes reflux disease. फिर for any reason there is delayed gastric emptying या फिर increased intra-abdominal pressure for any reason, most commonly in heavyweight individuals and pregnancy. We've already discussed this. Right, let's move forward. Acha. Oops. Let's just move back up. Right. Lower esophageal abnormalities, we already discussed this. Tone kam hai ya phir inappropriate relaxation ho raha hai. Hiatus hernia. Almost all patients that develop esophagitis, Barrett's esophagus, or peptic ulcer disease have hiatus hernia. So you can understand how common a hiatus hernia is. Important features kya hai? They're mentioned in this table. Herniation of the stomach through the diaphragm into the chest. It occurs in 30% of the population over the age of 50 years, so it's a very significant number. It's often asymptomatic. Heartburn and regurg can occur, and a gastric volvulus may complicate large hernias. Let's move forward. These are basically diagrams of our textbook, Davidson's, and I've taken simple screenshots. You can refer to your books as well. There are two types of hiatus hernia. One is the rolling or the paraesophageal hernia, and you can tell why it's called paraesophageal is because the herniation hai, it's parallel to the esophagus, right beside it. Or just sliding hernia hai, ye wala, so you can kind of understand like if a part of the stomach slides through here or thoda sa upar chala jaye. So these just shows a different type of hernia, and this is the barium meal जो दिखा रहा है दोनों hernias को. Just delayed esophageal clearance is one of the causes. This results in increased acid exposure time. जितना ज़्यादा time के लिए acid esophagus में रहेगा, उतने ज़्यादा severe symptoms होंगे. ठीक है, तो इस reduced peristaltic activity हो सकती है in many patients, but especially in patients with esophagitis, and this unfortunately persists even after the treatment of esophagitis. Defective gastric emptying की reason unknown hai, but it's also one of the causes. Then I've already mentioned this, and I've mentioned this too. Right, moving forward. This is really important clinical features because हमारे जब exam के अंदर कोई भी question stem होता है वो हमें clinical features से identify करना होता है. The number one clinical feature is heartburn and regurgitation, especially on bending, straining या lying down. You know, maybe कोई बंदा कहता है कि यार मैं रात को जो है ना मुझे बहुत ज़्यादा जलन होती है सीने में, ठीक है, या फिर कि मैं कोई भारी चीज़ उठाने की कोशिश करता हूँ तो मुझे जलन होना शुरू हो जाती है सीने में. फिर एक और really important clinical feature है water brash. ना इसका मतलब है salivation due to reflex salivary gland stimulation. Right? तो जैसे मुंह में एक how do I describe this? मुंह में एक जैसे अगर किसी को कभी एक्सपीरियंस हुआ हो like something like a खट्टा डकार and then उसके बाद अजीब सी salivation मुंह में आती है, this is kind of like water brash. Patient जो present होंगे they will often be overweight. कुछ पेशेंट्स जो है उनको रात को जाग आ जाती है because जो reflux है उसकी वजह से उनका larynx irritate होता है जिसकी वजह से वो choke करना शुरू हो जाते हैं. फिर dinophagia is also very common as well as dysphagia. फिर उनको हो सकती है chest pain similar to angina, or they can present with hoarseness of voice because of the reflux, उसकी वजह से laryngitis हो जाता है. They can have recurrent chest infections, chronic cough, and asthma. And sometimes the patients may only present with cough. Like आपको लगेगा भी नहीं कि कोई ये GIT का मसला है, ये लगेगा जैसे कोई lungs का मसला है, इस तरह की उसकी presentation होगी, ठीक है. अच्छा, अब complications क्या हो सकती हैं इसकी वजह से? It leads to esophagitis, जो हम देख सकते हैं endoscopy पर, as mild redness or even severe bleeding, ulceration, and strictures. कभी-कभार the biopsy may even be, the endoscopy may even be normal. उस केस में भी we'll still take a biopsy. Why? Because there could be eosinophilic esophagitis, right? Or some sort of histological esophagitis, जो हमें naked eye से नहीं नजर आ रहा, but histologically we can visualize it, right? Then Barrett's esophagus. Now हमने ये बहुत दफा पढ़ा है. It is intestinal metaplasia because of the reflux. This is a pre-malignant condition, and the risk factors are a white, male, obese, above 50, and a smoker. Alcohol is not associated with this. This is the genetic background of this carcinoma. The most important part we need to remember is diagnosis इसका कैसे होता है, endoscopy and biopsy, ठीक है, और management कैसे करनी है of Barrett's esophagus. We are going to be looking at this table, this flow chart, excuse me, and this makes it really simple. ठीक है, patient comes to us with severe heartburn, हम उसको endoscopy के लिए भेज देते हैं. हमने साथ में endoscopy की biopsy ले ली. Then we're going to determine what we need to do. If the patient has metaplasia but no dysplasia, and the segment is less than 3 centimeters, then we will tell them to have an endoscopy done every 3 to 5 years. Agar segment greater than 3 centimeter hai, so there will be an endoscopy done every 2 to 3 years, just to be sure, right? If the patient comes up with low-grade dysplasia, तो उसकी endoscopy करेंगे हर 6 months पे. And if the patient shows up with high-grade dysplasia or intramucosal carcinoma, then we're going to go for the proper treatment plan, esophagectomy, or endoscopic therapy, such as you can do resection plus radiofrequency ablation, right? So the basic concept here is catching that metaplasia or dysplasia before it becomes a carcinoma that can invade. Okay, so this is the management plan we follow for patients with Barrett's esophagus. And then obviously when it turns into a full-blown carcinoma, then uske liye puri multidisciplinary approach karni padti hai. You need to get all the departments involved, you need to stage it and all of that. Okay, Then the next complication of GERD is anemia. Iron deficiency anemia ho jata hai because of a long-standing esophagitis, which causes occult blood loss. Iske andar there are these lesions which have a very specific name, Cameron lesions. They're subtle erosions in the neck of the sac of the hiatus hernia. So there is a hernia. This is, as you can see, it's a sliding hernia. Niche stomach hai aur ye sphincter hona chahiye. And this is what a Cameron lesion would look like. Every time a patient presents to you and they have anemia and you do an endoscopy and you think, all right, this patient he's old, he's probably overweight. He has, on endoscopy, he definitely has Cameron lesions. So you're like, okay, he has esophagitis and he's had it for a long time, but you must always, always, always consider colorectal carcinoma, right? You should never skip this. Because patients that have anemia are old in age, they have a really high chance of having this. So always rule colorectal carcinoma out, even when the endoscopy reveals esophagitis. Right, moving forward, another complication of GERD is benign esophageal strictures. Benign esophageal strictures. This is also because of long-standing esophagitis. The presentation is an elderly patient who has a dysphagia, which is worse for solids than liquids, and they may or may not have a history of heartburn. The diagnosis is done on endoscopy and a biopsy is taken to rule out malignancy. And the treatment is with endoscopic balloon dilation or bouginage, which is basically dilation with a bougie. Plus, you give them proton pump inhibitors after the procedure to reduce the risk of recurrence of the esophagitis or the stricture formation, and advise them to chew their food properly and ensure adequate dentition. So I've put in some pictures of what a bougie looks like and what a balloon dilator looks like. And this is how the procedure is done. You put the deflated dilator in and then you inflate it and it just kind of stretches out the stricture. The next complication we have is gastric volvulus. A massive intrathoracic hiatus hernia may twist on itself and cause a complete obstruction. A lot of people, they don't understand exactly what a volvulus is, so I'm just going to attempt to draw one. I hope this makes sense. So this is a straight line. I am going to create a volvulus out of the straight line. So if I took this, suppose this is a string, and I twisted it on itself over here. So this is the string. I took the center part and I pulled it, and then I would begin to twist on itself, right? So I basically twisted it on itself, and this is a volvulus. And this is exactly what happens here. The part of the hernia that is intrathoracic, it twists on itself and basically compresses everything in the mediastinum, and in the process also causes complete obstruction of the tract. And the presentation is severe chest pain, vomiting, and dysphagia. You can imagine if there's a complete obstruction, obviously there's going to be vomiting and dysphagia, and this huge hernia in the thoracic region is crushing all the contents of the mediastinum, so it's causing severe chest pain. The diagnosis can be done on an X-ray chest. There's an air bubble in the chest, or on barium swallow. The treatment is, well, most cases they tend to resolve spontaneously. However, recurrence is very common. Then we have the investigations that should be done in GERD. So a patient presents to you with simple heartburn and maybe a few symptoms of GERD, and they're not that severe, and the patient is young and has no alarm features. You don't need to do any investigation. You can totally advise them to change their diet, to maybe lose some weight, etc., but they don't really need any investigations. If a young patient does present with alarm features, then you refer them to endoscopy, and if a patient is above 55, regardless of alarm features or not, they are going to have to get an endoscopy done. If the diagnosis is still unclear after the endoscopy, you get the patient to have a 24-hour pH monitoring, which is a gold standard for GERD. What you do is there is a pH monitoring catheter, and you put it into the esophagus near the lower part of the esophagus, right before there's a lower esophageal sphincter, and it basically monitors the pH of this area over a 24-hour period time, and then you can tell if the patient has GERD or not, has reflux or not. And a pH of less than 4 for 6 to 7% of the study time is considered diagnostic of reflux. Right, this is gold standard, and it's really important to remember that. Now we're going to move on to management. We usually just simply manage the symptoms of heartburn. So we're going to give them antacids or alginates, proton pump inhibitors at full dose. Then we're going to check their response. If they have a good response, then we're going to give them PPIs at maintenance doses, H2 receptor antagonists, antacids, right? If they have a poor response or they have side effects, we reconsider the diagnosis or consider pH monitoring. And if it's positive, then we go for fundoplication. We give the patient lifestyle advice. We ask them to lose weight, avoid food that worsens the symptoms, elevation of the bedhead to avoid nocturnal symptoms, avoid late meals, and the cessation of smoking, which is a really important factor in GERD. And this is almost necessary. If a patient has GERD and they are smoking, they need to stop smoking. If a patient doesn't improve after lifestyle changes, then you can offer them PPIs, which will relieve symptoms and heal esophagitis. Recurrence of symptoms is common if therapy is stopped, and some patients require lifelong therapy at the lowest acceptable dose. Dysmotility features, for dysmotility features, we give domperidone. There is no evidence that H. pylori eradication has any benefit. Antacids and alginates provide symptomatic benefit. H2 receptor antagonists relieve symptoms but do not treat esophagitis. The side effects of long-term PPIs are that they reduce the absorption of iron, B12, and magnesium. They increase the risk of osteoporosis and fractures, predisposed to infections by Salmonella, Campylobacter, C. difficile. They have an undesirable effect on the gut microbiota and increased risk of H. pylori associated gastric atrophy. Therefore, H. pylori eradication therapy must be given to patients who use PPI for more than 1 year. So remember, if someone is using PPIs and they use it for more than 1 year, you need to be giving them H. pylori eradication therapy. For the surgical treatment, we are going to be doing laparoscopic anti-reflux surgery, also known as fundoplication, as was previously mentioned in the chart for management. The last resort was fundoplication for patients who had a poor response to the conservative treatment. And often it leads to gas bloat syndrome, which is the inability to vomit, and abdominal distension. This is a complete, you can call it a side effect of the surgery or a complication after the surgery. And we have a really good picture showing exactly what fundoplication is. So they wrap the fundus of the stomach around the esophagus and stitch it together. And this causes narrowing of the esophageal sphincter. When I looked at rank order, GERD was one of the most important topics in the first order right here, and I looked at the syllabus, and GERD is right here. So you can only imagine how important it is. I'm going to be putting in some questions in this video so that you can test your knowledge. That's it for today. Thank you so much for listening.